Hello, welcome to another video journal club that Neurology is organizing. I have the pleasure of being here with Lucy Norcliffe-Kaufmann. I'm Alberto Espay from the Department of Neurology at the University of Cincinnati, and Lucy Norcliffe-Kaufmann is my favorite expert in the field of orthostatic hypotension, which is the topic we're going to be discussing here. Lucy is currently the lead for the scientific program for Parkinson's disease at 23andMe. We're going to be discussing this very interesting paper titled Association Between Orthostatic Hypotension and Dementia in Patients with Parkinson's Disease and Multiple Systems Atrophy. This was a paper published in the March 7 issue of Neurology. The first author is Inigo Ruiz Barrio, and the last senior author is Eduardo de Pablo Fernandez. There is plenty that this article will make us really think about, but I'm going to have Lucy give us a little bit of the summary of what this study was based on, what the hypothesis, and how it was conducted. Lucy, thank you again for accepting the challenge to be in this journal club.
Thanks, Alberto, for inviting me. This is a great opportunity to discuss this paper because I think it grapples with a really important question, which is, does early and more severe orthostatic hypotension contribute to the risk of dementia in patients with synucleinopathies, including Parkinson's disease and multiple system atrophy? It was using the retrospective data from the Queen Square Brain Bank, and the team here looked at the medical records of patients that were diagnosed neuropathologically with either Parkinson's disease or multiple system atrophy. And they trawled back through their clinical records, and they looked to pick up signs of either dementia or mild cognitive impairment as endpoints. And then they looked into the group and through their medical records to see whether they had either orthostatic hypertension, either blood pressure measurements showing that, or symptoms consistent with orthostatic hypertension that were lasting longer than 3 months and refractory to medical treatment. So what the team did with multivariable hazard regressions is look for the association of the risk between the two. And I think it was a reasonably good size of a sample, right? They had 132 patients with Parkinson's disease and 137 with multiple system atrophy. What we cannot forget here, of course, is how rare multiple system atrophy is compared to Parkinson's disease. So, that's a substantial number of MSA brains to have the vantage point on. I think the biggest finding of the study, of course, is that the prevalence of orthostatic hypertension is less in patients with Parkinson's disease, around 50%, and higher in patients with multiple system atrophy, around 80%. The prevalence of dementia was higher in patients with Parkinson's disease, around 57%, compared to the very low rates of frank dementia, as they call it, in patients with multiple system atrophy, that was 7%. Early OH seemed to increase the risk of dementia by about 14% per year in patients with Parkinson's disease, and increased the risk of mild cognitive impairment in patients with multiple system atrophy to around 41% per year, which it appears to be, very substantial as a risk factor. What's really interesting, and I'm dying to hear your view on this, is that these early OH findings were not associated with neuropathological changes. So there were no significant associations between the severity of OH symptoms and other clinical or neuropathologic variables. So the takeaway from this paper and the potential implication of this was that OH appears to contribute to cognitive decline in patients with PD and multiple system atrophy, but not through changes in pathology. So that's what we're here today to discuss. Alberto, I want to turn it over to you. What do you think the paper adds?
Well, thank you, Lucy, for summarizing so well. I actually really, truly think that this is a great paper and an excellent contribution to the literature. So I commend the authors for doing this. The key contribution, though, is the idea of assessing the independent effect of orthostatic hypotension to the cognitive function in a pathology confirmed cohort. So we rarely have studies of this kind where we have pathology confirmation, autopsy confirmation. So this is, I think, the most important aspect to it. And to say, as we can from this data, that orthostatic hypotension contributes to cognitive impairment, not by changes in pathology, by some other mechanism, and the author's postulate is must be hypoxia or chronic hypoxia. I think it's a very important conclusion, and is one that further detracts from the idea that it is pathology which mediates the toxicity of different aspects of our risk factors for dementia. In this case, this one is emerging, as you're saying, as a very important risk for cognitive impairment. And I think we'll have to discuss what the implications are for clinicians given the findings. From your perspective, what would you say is truly what might be the key takeaway from an expert on autonomic function?
I think one of the key takeaways here is that orthostatic hypertension might not be as benign as we think it is, right? And this association, because this association was found in people that had presumably more mild orthostatic hypertension, if it's just going by numbers, or more severe orthostatic hypertension if they're people that are still symptomatic and refractory to treatment, right? So I know we don't have, which is one of the limitations of this being a chart review, we don't have so much color on the participants to be able to really decide that, but we have to assume that they capture the people with a whole range of severities of orthostatic hypertension, not just including the timing and the onset. It's the cerebral blood flow is something that is so tightly controlled, right? I mean, you have blood pressure driving as a driving force, and then you have all autoregulatory mechanisms within the brain itself that help preserve flow. So clearly the brain does all it can, right, to try and preserve blood flow and avoid episodes of hypoxia. And these repeated episodes of hypoxia that people with OH have, right, every time they're standing, because it's such a chronic condition, one wonders, like, this has to, if you just think about it logically, have an impact on the underlying health of the underlying cells, right? So I really think that this expands us beyond the pathology and looking at like other factors that contribute to some of this cognitive decline.
Absolutely. Lucy, could you walk us through, and just trying to frame the limitation sections of the study, what is it that is required for a formal autonomic evaluation, and what of that would have been ideal to have in the study that perhaps wasn't part of the study?
That's a great question. And I think, one of the things that's missing really is the severity, right? The symptoms. I mean, it's the incapacity somebody has from the OH, because we know that OH in particularly in Parkinson's, right, it can be very mild, but at for the most times. But if you give somebody aggravating factors like a big meal or something like that, then they get this crashing hypotension. So, when you're doing a formal autonomic evaluation of somebody, I think the important thing is to listen to the person's story, to pick out, when is the time that they have the symptoms, like what are the provocative factors that are underlying that person. And then, of course, you want to look at the blood pressures in different positions, because that gravitational changes are going to have a big impact on blood pressure. So you lie the person down, you see if they have supine hypertension to begin with, if the blood pressure meets that criteria, and then you stand them up and you measure their blood pressure when they're standing after 3 minutes to see if it drops. one of the important things I think to pay attention to is the heart rate, right? Because that really helps you distinguish whether this is neurogenic orthostatic hypotension, when the heartbeat doesn't go up that much, less than half a beat per minute, per fall in millimeter of mercury blood pressure, versus somebody who's dehydrated with polycythemia but intact baroreflexes. You'll see that fall in blood pressure, but a big rise in heart rate, right? So that's what we always begin with autonomic testing. And then if necessary, you would do a full autonomic workup on somebody. You would put them on the tilt table. You would perform a Valsalva maneuver. You may want to look at catecholamine levels to be able to localize the lesion, which can, help you in the differential diagnosis, if that's a question. So, formal
How
autonomic.
does he help you? How does he help the catecholamine level, since you mentioned that?
It's a good question. Usually when you see a lot of peripheral denervation, that correlates with very low norepinephrine levels. And usually when you see normal to even higher catecholamine levels in multiple system atrophy, for example, it shows you that the postganglionic sympathetic fibers innervating the blood vessels are intact and releasing norepinephrine. Right. So you can also look at neurohormonal changes in vasopressin, which give you the afferent arm of the baroreflex. So there's a number of things you can do with neurocatecholamines that help lesion localization.
Thank you. Thank you. No, I'm glad. And what was it of this particular study that wasn't there? Obviously, this is a retrospective study. We had the cases and controls, the cases really, there are no controls, but cases of Parkinson's and cases of MSA drawn from an autopsy cohort. So missing data probably is part of the problem here to some extent. But of the data available, is that data good enough for you to have a good sense of what the autonomic function was in general and what the orthostatic hypotension prevalence was in particular?
I think that's an excellent question, and it's one that I go back and forward on, because I think that we have to commend the study group, right, for the idea and going into that data set and looking at it in such a careful way, and understand that you get what you get, right? This is a retrospective cohort. But, the selection criteria for who they defined had OH and didn't have OH, I think are a little vague, right? And then it makes it difficult for us to be able to harmonize other retrospective data sets if we're all looking at slightly different endpoints. They had of course 2010 fall as an entry criteria, which is the accepted definition for picking up orthostatic hypotension if the systolic falls by 20 or the diastolic falls by 10 within 3 minutes of standing. But they also used people could come into the cohort with defined as having OH if they had the presence of symptoms for 6 months or longer after therapeutic measures had been implemented, right? So they had presumably chronic OH that was refractory to treatment. So really, I mean, they cast a wide net to capture OH. Can we tease it apart in terms of the severity? Probably not, right? But, I think one of the things that would be nice is if we could come up with ways to harmonize other data sets so we can reproduce these findings, or we can expand on them. But if we're, OH is not so simple, right? So having standardized measures, I think, would be good.
Talking about standardization of measures, the authors divide OH into early versus late, and they use that on the median value of OH. What do you think of that?
I mean, I don't know. I think it's a really good question, because one would assume the longer you have OH for, the more either it gets worse, which we don't fully know, or the more time it has to contribute to a pathological implication, right? So I get the logic of doing it, but I wonder what your thoughts are in dichotomizing the data set like that. Is it the right approach? Do we have something better?
Right. No, and I don't know if we have something better. I think in general, whenever we dichotomize data of any kind, we're assuming low, high must be quite different. And And to be honest, it's a riskier, statistically speaking, proposition, because you're going to treat that data in a manner that is less powerful to find differences. But as the authors show, there was a great difference between early and late. So to your point, early, if just simply defined by anyone below that median that was for everyone in terms of time to OH, then the earlier, the worse. But essentially, the greater the association with cognitive impairment in the case of MSA, or dementia in the case of Parkinson's. So I think it's probably what they could do. I'm sure they could have done quartiles, or they could have just treated it differently. But I'm curious, because it's certainly not necessarily something that we think of in terms of when we see patients. We don't think of them whether they are in the early or in the late OH onset category.
Mm-hmm.
So it's more of a statistical artifact, but it's I don't think that there is a reason for us to think it's not a valid way of doing it. Now, the one thing though that it isn't, and I wasn't necessarily attuned to, was the severity of measures, right? So the idea was that there was a scale 0 to 4, I believe it was, where you would measure how severe this was. By the way, it's very intuitive. You go from mild, which would be you have it, but you don't require any treatment, to severe, where you really, really require treatment and you still have a lot of problems, even though I'm not paraphrasing it quite correctly, but that's the direction. What do you think about this concept of OH being differentially thought of as to whether it's symptomatic and in whatever gradient of symptoms we have it, versus asymptomatic? Does it matter?
That's I go back and forward on that, because you see studies like this where we don't know if all these people were symptomatic, but we find a link with dementia. And I think one of the really difficult things when you're trying to associate symptoms and blood pressure is that the relationship is often not linear, right? And there's autoregulation that's in that process, right, that is helping to protect the brain. But on top of that, you also see that there are many patients that they have symptoms. Their look is glazed over. They're slower to respond to you. You're sort of like, do you want to sit down? Do you want? And the person is like, it doesn't say they have symptoms, right? There's such a symptom unawareness in many patients with chronic orthostatic hypotension that simply asking them, do you have symptoms, may not always for all people capture whether they have subtle symptoms, whether they have, they're on the verge of blacking out and they're just not recognizing it. And I think, we assume that particularly in Parkinson's disease, people can accurately report their symptoms, but many times, you see it in somebody and they're unaware, or they're so used to having this as a chronic condition that they don't recognize what it is to stand up with normal perfusion, right? So I really have a hard time in should we really and then for clinical practice, they rely on symptoms, not on treating numbers, right? Absolutely. So, and when developing therapies for orthostatic hypotension, it's based on symptom improvement, right? Not blood pressure. So I think there are pros and cons of using each one. I think they probably shouldn't be used independently, and they're more powerful when put together.
Yeah. Well, the other problem with symptomatic is that what is classified as a symptom of OH. And in clinical trials, we use postural lightheadedness, the sense of whether somebody might feel as if it could black out, right? That will be the one symptom that we for sure know is related to OH. But what about people who have cognitive impairment? What about people who are fatigued? What about people who have freezing of gait? What about people who are falling? Are they asymptomatic? Just because they don't acknowledge postural lightheadedness? Probably not. Probably they're symptomatic. But in our narrow definition of what is a symptomatic OH, they are asymptomatic.
Yeah.
Aristide Merola actually brought up this concept to me when he was in Cincinnati. He did a study with consecutive patients with Parkinson's disease, the orthostatic vitals in all of them, and found and classified them whether they have OH versus not OH. and whether they were symptomatic or not, based on the standard definition, and found that there was an equal chance. By the way, 40% of people who had OH were asymptomatic. But when compared to symptomatic OH, they had equal levels of disability, equal levels of healthcare utilization, equal levels of quality of life impairment. So it wasn't as if the symptomatics were worse. I have been thinking about this, and I'm thinking, actually, if you no longer have the ability to recognize that you are standing and therefore your blood pressure is falling, and you don't feel that as a lightheadedness, you've compensated for that, but then other things must suffer, among them cognitive impairment. And to your point, maybe as part of that cognitive impairment that comes on, then you are unable to recognize that there any lightheadedness. So it's actually potentially worse not to have lightheadedness from standing, because it implies a chronic process that has already affected cognition.
And we saw also, Alberto, the flip side of that, the opposite side of the coin, which we published in Neurology a couple of years ago. We encountered 3 patients that with Parkinson's disease that were reporting stories of orthostatic hypotension. And when it was almost textbook, right? I stand up, I feel dizzy, I sit down, I feel better. It's worse in the morning. So we found no autonomic abnormalities in these people, and we looked for them. Their cerebral blood flow was like well maintained when they were standing up, so they were experiencing dizziness, postural dizziness, like you're talking about, that had a textbook story of OH, but it wasn't, because the blood pressure wasn't falling. So that's why I think, like, when it comes to just using symptoms alone for a diagnosis, like dizziness, lightheadedness is so vague, right? And can be due to the other influences on the postural reflexes, right? That we may be oversensitive, we may be undersensitive, but we may not have a totally clean cohort of people with OH if we just go for symptoms alone.
Absolutely. Well, in this period of time, I want to jump into the implications for clinicians. What would you say? You're going to start with the first implications you think of, and I'll follow with the second.
I think the first implication to think of is OH as benign as we really think it is, right? If we found a bigger risk for dementia in people with synucleinopathies, should we just be waiting for people to tell us I'm really symptomatic and fainting before we start thinking about putting them on the step towards treatment, right? That for me, I think, was one of the biggest takeaways from this.
Right, absolutely. And I think the answer to that question, of course, provocatively put by you, is no, we shouldn't be waiting for that. And so that then related second implication is that the orthostatic vitals should be undertaken in everyone with Parkinson's disease and with other synucleinopathies, Parkinson's disease, dementia, and dementia with Lewy bodies, because we know that even in the absence of symptoms, and this study showed that symptom severity had really not relevance. It was just the presence of OH rather than how much of a severe expression of it would be. It was just that presence associated with cognitive impairment in a manner that independently predicted that. So I think that we are going to have to reckon with the concept that the vitals should, in these patients, include an orthostatic assessment.
Absolutely. That I think is one of the most critical things. And I know advocacy groups and others have worked hard to push for this to happen, right?
Yeah, it takes time. And I think that's why it's so hard. It would add another 8 minutes, right, by the time to go through the whole process. And that is probably where the limitation is. Now, I'm going to argue, and I'm very curious about your thoughts, that the third implication, and perhaps it's one that is sort of hidden in plain sight in this paper, but the concept is that supine hypertension, which you would think if anybody has OH because of the neurogenic reasons for it, that you are going to have low and high blood pressure. So most people with OH will have supine hypertension, which is why we ask them not to be in a recumbent position throughout the day. But for what they could do, there was absolutely no relationship between supine hypertension and any cognitive risk. So a third potential implication for clinicians is to perhaps lose the fear for supine hypertension as an obstacle to optimizing the treatment for orthostatic hypotension, and that perhaps the treatment of orthostatic hypotension, if we truly do it well, will require accepting that there will be more episodes of supine hypertension with fewer episodes of hypotension, but overall a greater cognitive benefit, perhaps without any of the risk factors we think of associated with chronic essential hypertension. What do you think?
I think it's a really, we go back and forth, right? And the studies of finding an association between supine hypertension and organ damage, let's just, the brain and other areas, I think they always come out very mixed, right? Either some find an association, some don't, right? I think it also depends on like how low you go, right? Which, there's a difference if you're falling from like, say, 160 to 140, even to 120, you're still above that autoregulatory range, right? So, it's not just the fall, it's how low you go, right? It is a very important factor for OH, right? But definitely, it makes sense to there are so many numbers, right, that one has to take into consideration for this. But, generally, I think, there could be more tolerance for supine hypertension, because that definitely helps bring up that blood pressure when somebody's standing above the limit of autoregulation. The other thing that I think is really interesting is the possibility of drugs that enhance the effect of norepinephrine or when people are standing, right? Because most of the pressor agents we have work in the supine and standing position. So they either cause total vascular constriction or they expand intravascular volume. So they move the pressure up all the time, right, off the various periods of time. But having drugs that could selectively have a greater impact when you're standing up, I think would be another important step forward in the treatment for OH to mitigate the potential of supine hypertension.
Absolutely. Well, that brings us to the what comes next section. What would you say, Lucy, is the thing that we had to do next in our research to understand this idea better?
I think one of the things that I would like to turn this question back over to you, right? Because I think that the pathology, the cross pathology and the co-pathology is something that I know you are very fascinated with this paper. So I wonder if, you want to talk a little bit about the implications of what comes next in terms of like the pathology findings we saw.
Well, thank you, Lucy. Yeah, I appreciate the opportunity. I would say that this is yet another expression that pathology is the sign of a brain fighting against something, and that something is different in different people, because principles of precision medicine dictate that not two people with Parkinson's disease are really alike, and therefore what's common between them, pathology, might not be pathogenic in each. And this is yet another piece of evidence in that direction. So what we need to do, I think, moving forward related to this is to begin to remember that pathology is one end of the protein homeostasis, that the proteinopathy story has two parts, begins with normal protein and ends with pathology. Pathology today was normal protein yesterday. So we cannot simply eliminate one side of the story and just talk about pathology going up, when in fact there is no net gain of proteins. The brain continues to shrink, as we had discussed just before. And so if we begin to start in our research to present the two sides of the story, I think it would be very important. In autopsy studies, I used to think that you can only report the insoluble fraction of the protein, which was the pathology, because the soluble fraction was long gone. But Glenda Halliday from Australia has done wonderful work that can show, in fact, or testifies that there is a way of measuring the soluble fraction in tissue. So if you can present those two sections to parts of the story, will be very important. As the insoluble fraction goes up, generally speaking, the soluble goes down, and that's something that she's shown. So it'd be nice to in future studies see those two sides of the story. Now, I, of course, think that all good studies lead to a lot of questions. This one is not exception. And of course, prospective intervention will be needed, really. And here, I think we have an opportunity, of course, to see that a technically modifiable risk factor for cognitive impairment is a low-hanging fruit. It's there, we recognize it, it's common, and is independently contributing to cognition. So we really need to test this in a randomized control fashion. And with the idea that supine hypertension might not be that difficult a problem. By definition, it's paroxysmal, not quite having perhaps the long-term effects of chronic essential hypertension. We might be a bit more aggressive with this. So I think that would be very, very important. What would you say, from your perspective and as an autonomic expert, the next phase of knowledge would take us to?
I think you're right that we need prospective work to be able to figure out if we modify and we treat orthostatic hypotension, do we alter the risk of complications like dementia, if that association is true. I think what would help going forward is to have more standard definitions of these endpoints, right? Because there are multiple retrospective and prospective data sets now, right? But if we all use slightly different definitions of what's dementia, what's versus frank dementia, what's mild cognitive impairment, what's, they had another one, that the subcortical cognitive syndrome they mentioned in the paper. And I think if we had standardized ways of at least recognizing this in a person, that would help us harmonize data sets and look at these on a bigger scale, right? And then, move this into a prospective study, like you say, where we could really, test these hypotheses and grapple with, like, how much supine hypertension is too much, like what's the optimum blood pressure level we should be maintaining people above, right, to be protective. I think there's a lot of work that needs to be done, but there's a lot of thinking that needs to happen around the right design, the right endpoints, and the right way to categorize people.
For sure. Lucy, you've been wonderful. I wanted to thank you for enlightening me and our audience. The Video Journal Club is all the richer because of you, and I'm thankful for all the effort you put into dissecting this excellent paper, Association between Orthostatic Hypotension and Dementia in Patients with Parkinson's Disease and Multiple System Atrophy. I think that there will be a lot that we will be learning in the future as a result of this effort. I commend the authors for what they did, and thank you to Neurology for putting this together. And again, all the very best to you. Thank you. And
thank you, Alberto.
That concludes the session. Thank you very much, Lucy.